Hey there, it's Dr. Justin Marcagiani. Welcome to Beyond Wellness Radio, where we provide actionable health information on a week-to-week basis that can help you improve your life. Feel free, head over to justinhealth.com, where we have various opt-in video series on more in-depth health topics such as female hormones, thyroid, and gut health. Also, while you're there, feel free and schedule a consult with myself, Dr. J, and or my colleagues. We're available worldwide to provide natural health support for any of your major health issues. Again, welcome to the podcast and enjoy the show. Hey guys, it's Dr. Justin Marcagiani here. Really excited. Today we're going to be having a phenomenal podcast on the topic of conventional medicine GI workup versus a functional medicine GI workup. We want to just kind of give you guys a little compare and contrast and talk about where others shine and where others may be better, especially for most people who have chronic health challenges that may be missed by your conventional medical workup. Before we dive in, Evan, how are we doing today, man?
Doing really well. This podcast started with a story, quick story. The best man in my wedding, he called me last night and, hey, how you doing? Everything's good? Okay, awesome. And then, hey, I need some help with my wife. She's been having a lot of gut issues for the past several months. She went into conventional doctor, then went to I'm assuming she went to some type of a specialist, GI probably, and told them about her issues, which were bloating, major abdominal cramping and pain, floating stools, possibly some changes with mood, but I don't know if that was brought up to the doctor. So just conventional GI stuff, and some pain that was radiating to the back. So pain in the front that was then radiating to the back. And her protocol was no testing. I don't even think they did palpation. They didn't do physical exam. I think they just listened. And then they said, okay, buy this probiotic. This probiotic was something that you and I looked up. It was one strain of bacteria in the Bifido family, and it was loaded with fillers. And it was what's considered a consumer grade product, meaning you don't have to be a practitioner to get it. And it was just loaded with garbage fillers and sugar and other stuff. It had sucrose. Like, why do you have sucrose? So that was it. And so then when you and I called this morning, I just said, look, we've got to cover this because she got nowhere. And she spent all this time sitting in a doctor's office waiting, and now she's no better off. So I talked with her for a little bit, and we made a protocol for her that I think is going to be far, far better.
That's great. Yeah, so really excellent. I mean, when we see patients on the functional medicine side, most have already gone through a pretty thorough conventional workup. So, my perspective on a lot of this, not that I'm a trained gastroenterologist, I'm not, we're functional medicine practitioners, but I see lots of patients who have already been through the gamut. And so I really try to understand what's already been looked at, what's been tested. And you see a pattern, when you see a couple hundred patients kind of go through these intense workups, you see a pattern of what's already been done. And you can kind of see what's been missed or kind of what their perspective is. So most conventional GI doctors, these are ones that are not functional medicine or nutritionally changed, right? 90% are going to be in the conventional category, right? They're just following the typical internal medicine, gastroenterologist kind of best practices workup. So most are coming in, they're doing a history. They may do a physical exam, some kind of a palpation to see where inflammation may be in the intestinal tract, right? Certain areas may lead them to think certain things, right? Upper left quadrant, right? My left. That could be stomach kind of things, maybe pancreas things. Upper right could be more on the gallbladder, liver area. Bottom, like mid left could be more spleen. Bottom right, mid right could be more intestines. And then lower right and lower left could be either appendix on the right, could be colon, ascending on the right, descending on the left, sigmoid colon on the left. So that you kind of get a decent area if you just know the general anatomy of what the inflammation could be. Now, the next step is going to be depending upon, how invasive things need to go, right? They may recommend a capsule or endoscopy just to get a window of what kind of inflammation is in the intestine. And then almost always, they may need to go deeper into an actual endoscopy, which is scope down the mouth, right? Colonoscopy is going to be scope up the rectum to look in the colon area, right? You have your sigmoidoscopy, which is the last part of the colon before stool goes into the toilet. And then you have all the way up the different intestinal tracts in the colon, right? You have your descending, your transverse, your ascending. And then on the upper side, you have your tummy, You have your tummy on the endoscopy, and then you have the first part of that small intestine. So obviously on the colon, they may be looking for, if you're older, maybe polyps, which could be precancerous. They may be looking at inflamed tissue. It could be inflamed tissue from a ulcerative colitis where maybe there's bleeding. It could be inflamed tissue from Crohn's disease, which may manifest a little bit differently higher up usually. And usually there's some level of skip lesions where ulcerative colitis may not have that. On the upper side, there could be ulcers in the stomach, right? Those are all possible things. And then there may be other tests to look at the levels of blood. There may be things done like a fecal occult blood where they're testing microscopic levels of blood in the stool. We may be looking at calprotectin, which are inflammation markers in the intestines. Maybe doing a barium swallow to look for any fistulas or blockages or even bleeding on a barium swallow. Those are all like conventional things. They may pull out a ultrasound to look deeper at pancreas or gallbladder or liver if some of that area comes back inflamed, or to even monitor some of the Crohn's type of inflammation. Some of the more progressive gastroenterologists are starting to do more of the breath testing. The lactulose breath testing, which may look at hydrogen and methane gases. Some may even do a glucose type of breath testing that looks at more of the bacterial imbalances in the stomach. These are all other more progressive, forward-thinking, kind of functional medicine, functional GIs may be doing that. Not a lot do that, though. And then after that, you have your conventional blood test, which could look for inflammation or immune cells or calprotectin or actually, no, calprotectin has to be in the stool, but you could look at C-reactive protein. You could look at immune markers, right? You could also look at in the blood, you could just look at red blood cells, hemoglobin, hematocrit, iron, because if you're losing blood, you may see it on a panel like that as well. And then some may also do stool testing. Now, they may do more of your conventional stool testing that is less accurate, less specific, maybe not the more cutting-edge DNA testing that's looking for microbes at a more sensitive level, parasites, h. pylori virulence factors, candida, SIBO, bacterial overgrowth, right? Elastase, steatocrit. Elastase is an enzyme marker. Steatocrit's a maldigested fat marker. So these are things that they're typically not going to look at that we're going to really dive in deeper because we're doing a real functional assessment for what's happening in the gut. Conventional medicine is more looking at a pathological assessment where we're looking at, hey, here's optimal digestion. What's functionally not working compared to optimal? Because there's a big spread between being functionally optimal and being diseased and pathological. There's a big spread. So the problem is a lot of people are in between. This is where diagnosis happens. This is where optimal is. And they may be somewhere in between that area, and they're just not going to get picked up. They're not going to get assessed or found. And that's where most 90% are going to be in no man's land in regards to their assessment or diagnosis. Now, we can go into treatment next, but I'm going to just pause there and give you a chance to comment.
Sure. Yeah. Good overview. And H. pylori breath testing is sometimes done.
Oh, I forgot H. pylori. I'm sorry. Yes, H. pylori as well.
Yeah.
Breath or stool.
So that's something where, if we typically what Justin and I are doing when we work with someone is we're going to have them send us any labs that they've done maybe the last 6 months, maybe a year if we think it's still relevant, and we'll take a look at it. So H. pylori breath testing, we'll see those, but the truth is that there can, with all these conventional, less accurate tests, there can be an issue with false negatives. So that's even more frustrating for the client or the patient because they come to us, they've got 5 or 6 things they've done with the GI people, and they still don't have any answers, and of course they don't have any action plan or protocol. So for me, before I figured out that I had H. pylori and parasite issues, I did the barium swallow. You drink barium, which is terrible. It's like drinking chalk. And then you go and you get an x-ray. I was having a ton of GI burning, upper GI burning. So that's where they did you swallow it and then you basically lay back. They then x-ray you and try to see what was going on. And of course, I wish I didn't have that done because it wasn't functional and it gave me no answers. And all they said was, yeah, you may have some inflammation. They just call it idiopathic gastritis. And then they send you on your way. They don't know. Yeah, meaning idiot gastritis. We don't have a clue. And then they gave me the recommended acid blocker and the antispasmodic and sent me on my way. And I said, I'm not taking them. Don't even give me the prescription pad. I'm not going to take it. And then luckily I was able to do functional testing, which then confirmed the bugs that I had. So I've been there. Done that. And you made a great point. I just want to kind of restate it in a different way just to make sure people are clear with it, which is this huge, wide like you call it, a spectrum. The spectrum of all the way over on one side is death, disease, celiac, Crohn's, just like some sort of, like you said, a pathological diagnosis. And then on the other end is like optimal gut health. And you could be so far down this hole, very, very close to pathological level of tissue destruction in the gut, but still not enough to technically be celiac or be Crohn's or be this or that. So until you get to that level, to the conventional world, you're fine. You just got to keep going until you get to the level of tissue destruction where you could say you are celiac or Crohn's or pancolitis or whatever. Now we can prescribe you this drug. And that's it. And I've actually had doctors tell some of my clients during their workups, hey, sorry, you're not there yet. You're not bad enough yet. You're not sick enough yet. We can't do anything until you get to this point. Like with thyroid, your thyroid's not destroyed enough where we're going to put you on this drug or we're going to cut your thyroid out. So just keep living as if you're living now. Once you're bad enough, then call us back and we'll cut your thyroid out, or we'll cut out your colon if it's diverticulitis. We're going to wait until you're in really bad shape. We'll go ahead and do surgery. Let's cut a foot of your intestines out. Yay. No, that's not the answer.
Exactly. And then just to kind of echo on it, because we see a lot of H. pylori, and conventional medicine may do a endoscopy for that, where they're taking a sample in the upper intestinal tract via the scope. They may do a stool antigen that may or may not pick it up. And then they'll typically do the breath testing. And like, there's different kinds of breath testing, as I already alluded, right? You have your lactulose, which is going to be more your SIBO breath test that'll look at hydrogen and methane. You have your glucose, which may look at upper intestinal, upper gut, stomach type of bacterial overgrowth, right? Lactulose takes about 2 hours to work through the full stomach to small intestine. So anything after 2 hours is usually a pretty good window into the colon, because that's where lactulose starts to get absorbed by the bigger bacteria in the colon. But glucose tends to get absorbed a lot faster in that first, 20 to 40 minutes. So it gives you a better window of the stomach. And then you have your H. pylori breath test, where they're giving you, like, it's a urea breath test. They're giving you like a urea tablet or a urea solution. And basically the H. pylori in your stomach will take their urea, right? Because typically how H. pylori works, it makes an enzyme called urease, and that metabolizes the urea and the protein into ammonia and CO2. So when you give that urea, the H. pylori will convert a lot of it into CO2 and ammonia. Ammonia has a pH of 11, so it's very alkaline, so that throws off your stomach digestion and it lowers your stomach acid, but it also spits off a lot more CO2. So then they're measuring high amounts of CO2 to get a window if you're positive for H. pylori on that conventional H. pylori breath test. So they're looking at three things typically. They're looking at breath, maybe a stool antigen, which is the stool under a microscope. They're looking at maybe an endoscopy if it's more serious to rule out gastritis or ulcers. And then maybe a blood test where they'll look at like an IgG, IgM, or IgA. And IgG is more of a long-term marker, so you really want to request an IgM, IgA to see if it's more active and acute. So those are the big things that they're going to be looking at on the H. pylori side. And I just say that because H. pylori is a big thing that we find a lot and can be a problem in a large percent of the population, up to 30 to 50%. And then I would say things like candida or a fungal overgrowth are very rarely looked at or assessed. And we'll typically look for that in the stool. And we'll also look for that in the urine via a functional dearabinitol test. So we'll look at things with a good functional stool assessment. We'll also maybe do that SIBO breath test, that lactulose SIBO breath test. Now, most conventional GI docs don't do it. There are some like forward-thinking conventional MDs that are gastro docs, like Dr. Pimentel out of Cedars-Sinai. He started making more of the breath testing more mainstream on the conventional side, which is good, which is excellent, but still a lot of conventional docs aren't even doing it. So we'll do that and we'll look at it. We'll run the more progressive, sensitive DNA stool tests, and that we'll also look at the urine test, which can look at bacteria in the urine. And it can also look at fungus in the urine, the dearabinitol, or it can look at the hipparate and the indican, which is a marker for bacterial overgrowth, as well as protein putrefaction, not breaking down your protein. So benzoate's another big one. Dearabinitol or dearabinitic is the fungus. And those are hippurate's another big one. There's a couple of 2-phenylacetic acid is another big one. There's about 10 markers that we'll look at for bacterial overgrowth on an organic acid.
And none of the stuff that we're going to do is going to be invasive at all. We're going to get into kind of we'll compare and contrast some of the treatment options too. But yeah, regarding the testing, the stool that we're going to do, it's an at-home stool test. It's going to be way more accurate. I'd like to put a number on it and say 100 times more accurate and sensitive, but I don't know the exact number. I would just say that we've had hundreds and hundreds of people who've done conventional testing through their practitioners. They show up with nothing. Even like doctor's data has missed infections, for example. But this DNA stuff that we'll run, we'll find or fill in the gaps where the other testing failed or lacked. So that's going to be the at-home stool testing, and then the organic acids testing. That's amazing. I mean, that even finds stuff that the stool test doesn't find, like the yeast overgrowth. And it's all
nice.
done at your house.
It's
amazing.
Nice. Yeah, it's very, very nice. It's non-invasive. I'll tell you, the problem with a lot of the conventional medical assessment, if they're doing a breath test, fine. If they're, obviously a good palpation is really nice, especially when it's acute. Conventional medicine's really good at finding irritable bowel disease, like, Crohn's, ulcerative colitis, or something more like an ulceration. If you're older, they can be helpful at like precancerous polyps, but even that, they don't address why those polyps grow. That's another conversation. So they're really good at finding those kind of things. But the question is, how do we get there? Is that underlying cause being addressed? A lot of times it's not. And then a lot of times it's being managed with PPIs, proton pump inhibitors, maybe a corticosteroid, some kind of they have natural coating products that kind of coat the gut but still don't fix the underlying issue. Maybe Imodium or some kind of antispasmodic or anti-nausea medication, especially when IBS is a diagnosis, because a lot of IBS type of diagnoses are diagnoses of exclusion, meaning they've ruled everything out. Therefore, they give you this diagnosis, which means, hey, you have some symptoms, but we have no idea why it's caused or what the cause is. So they give you this diagnosis. You feel comfortable that you got a label, but that diagnosis is a diagnosis of exclusion. It's you ruled these things out, therefore it has to be this. That tells you nothing about root underlying cause, and you're still recommended just certain medications that control the symptoms and may create more problems over time. Like if you're on chronic acid blockers, you're going to have issues with minerals and digesting protein and digesting fats, and over time you can have some serious nutrient deficiencies for sure.
And then you're going to have mood issues. You're going to have sleep issues because now you're not making neurotransmitters from the amino acids. So now you're irritable, you're anxious, you're depressed, you can't sleep at night, and your gut's still a wreck. And that was me. And I got the diagnosis of IBS, and it was nothing but drugs. And back to my friend's wife. So they recommended, we talked about that probiotic. It was just one strain, and it had a bunch of garbage fillers in it. And they also, of course, told her, eat more fiber. And this is a woman who's basically pescatarian, and she's eating cooked organic vegetables at almost every meal. I'm like, wow. So they told you eat more fiber. Did they even ask you about your diet? No, of course they didn't. They didn't ask you what you're eating. I mean, vets are better at helping with gut issues in dogs than GI docs are at helping with GI issues in humans. Why? Well, because the first thing you do when you go into the vet, what's the vet going to say? Oh, what kind of food are you feeding him? You go in, you take your puppy in. Oh, my puppy's, got diarrhea. Oh, what are you feeding your puppy? But that's not the first question the GI doc asks. Now, it's not the first question we ask either.
Great point.
But it's definitely in our workup.
Oh, it's something that's going to be asked on day one, and is one of the most important things for sure. Mm-hmm. But kind of getting back to the conventional side, because I really want to give conventional medicine its due. Hat tip where it's good. It's really good at a lot of these conventional, irritable bowel diseases or extreme ulcerations. They're just still not good at getting to the underlying issue. So let's say you have an irritable bowel disease, right? They may give you something like a Lialda or a mesalamine or a corticosteroid or a biologic or an immunosuppressant or some type of antispasmodic or Imodium, just something to manage those symptoms. If it's bad enough, they may give you even a chemotherapy, like a methotrexate, something like that. They may do deeper testing like a CT scan if they're looking at things, or a MRI, which doesn't have the radiation. CT has the radiation. So they may do deeper testing for that. A lot of times they're still going to want to go inside and do that colonoscopy or endoscopy for sure, which has its own host of issues because you typically have to be under anesthesia for those, okay? And anesthesia has a major negative impact on your gut flora. And sometimes they may even want you to be on antibiotics post-treatment sometimes. So it just depends upon the doctor and kind of your situation. But the anesthesia could have some negative impacts on it. And there's some data, it's more controversial, but I'll put it out there, but there's some data talking about the fact that the equipment that is used to do a colonoscopy, the cameras or endoscopy, cannot fully get sanitized due to the sensitivity of the equipment. It can't fully get sanitized. Therefore, there could be some potential fecal debris on there from a previous patient. It's possible, right? It's more controversial, but it's out there.
I don't think it's controversial. I've seen it for years, man. They call them HAIs, hospital-acquired infection.
Yep.
It's huge. It's one of the leading causes of death in a hospital setting is an infection that you pick up by getting a routine procedure done. I actually had a woman who had this happen, and she developed major C. diff infection. So she had issues before. She was having a lot of stomach pain, a lot of burning. She went to the gastro. They did the endoscope, and after she got home, she had endless, almost to the point where it killed her, diarrhea. And I was like, uh-oh, that doesn't sound good. And guess what? She had Clostridia difficile, also known as C. diff. So then what happened? She gets the conventional GI docs to prescribe her antibiotics, very, very strong antibiotics. However, C. diff is just one of the major bacterial infections that's become resistant to the antibiotics. The CDC's been warning about this for years. They now call what we're in now as the post-antibiotic era. Just look up CDC post-antibiotic era. You could read about it. And so this woman still had C. diff. She did the antibiotics. She killed off any remaining good bacteria with that, and she was still miserable. We ran the testing on her, confirmed the C. diff was there via urine and stool, and then we used antimicrobial herbs, and guess what? We got the woman better. We got the C. diff gone, and she was fine. So I'm glad that you pointed out they are good at finding stuff that's pathological.
Yes.
But even then, they're not going to tell you why you have Crohn's, and they're not going to put you on an autoimmune paleo diet like we are.
Exactly. They're not going to do that. Now, just to kind of highlight a couple things here, we talked about the hospital-acquired infection. There's also a chance of, rupture or, poking a hole with the cameras that are going into your throat or into your rectum as well. It's always a possibility. So the nice thing about some of the assessment and testing that we do, there's no chance of any side effects, which is excellent. And there's no chance of disrupting your flora either with anesthesia or swallowing radioactive solution, right? So it's nice to have an assessment that doesn't have really a chance of causing any more problem. And it gives you that full spectrum. Because remember, on the conventional medicine side, unless there's this much inflammation on the scale, here's optimal, here's a diagnosed visible condition. There's a large gap here. And if you're somewhere in this gray area, this is the gray area where the doctor says, hey, we can't help you. Hey, it's all in your head. Hey, you're just getting older. Here's a prescription for an antidepressant. Like, literally, these are things that happen after the fact. And there are some doctors that are saying, oh, well, here's a probiotic, like you mentioned with your friend that called you, and they recommended a crappy antibiotic, right? Now, hey, that's better than jumping on the antidepressant, right? That's at least a good step in the right direction. I appreciate the thought, right? A for effort, but outcome, not quite. And so the people are starting to wake up a little bit, and I think doctors are understanding that patients are going above and beyond, and they're reaching out to doctors like us. So some, not a lot, are trying to get their game stepped up for sure.
Yeah, and the other story I had in my head, I may have mentioned this before, but a male client of mine, he went in and got an endoscopy, and I don't know exactly what part, what material, what piece of the equipment, but anyway, he has a piece of equipment stuck in his body. And he has to go in for surgery now to get that piece of equipment removed. And he just went in for a routine scan, endoscope, and now he's got something stuck inside of him. And now they got to cut him open and get it out, versus we're having you wake up and pee in a cup at your house and mail it to a lab, and we're getting hundreds of biomarkers from that, and we're having you poop into a tray and you scoop that into the collection tube, and you're also doing that at home and you're sending that into the lab. So, I mean, just in terms of ease, and we've talked with quite a lot of few people who they're worried about their immune system, so they don't want to go around a hospital anyway, where there may be people that they could get exposed to COVID.
Yeah.
So we're saying, look, don't worry. You've never had to go anywhere, and with our practice, you still don't have to go anywhere. And we'll still mail you everything. You don't even have to go to a pharmacy to pick it up. We're going to mail you what you need to your door. So that's fun.
A lot more convenient, for sure. Love it. So I think we did a pretty good job. Now, we'll just kind of compare and contrast a lot of the treatments, right? Because I have my 6R protocol on how we work on supporting someone's health. So, of course, gastroenterologists are typically going to make 0 recommendations on food. Now, some of the more progressive ones may say, hey, cut out gluten, dairy, refined sugar. That could be common. That a lot of times that's not going to be enough. Or they'll recommend a conventional low FODMAP diet, which could still have other grains and other inflammatory foods in it. So that still may not be great. So we have kind of our own special kinds of diets that we use, whether it's a specific carbohydrate diet, cutting out phenols, salicylates, whether it's an autoimmune diet, which is kind of paleo plus, right? Paleo is no grains, legumes, dairy, right? Autoimmune's no nuts, seeds, nightshades, eggs. We may do a keto, we may do a carnivore, we may look at cutting out histamines. There's a lot of different dietary templates that we have used thousands of times, and we kind of know where the best ones to apply are. That's important because 9 times out of 10, your conventional doc won't even touch that, okay? Next up is we're going to recommend digestive support. Now, your conventional doc's more likely to prescribe an acid blocker than anything to help improve digestion. Now, an acid blocker may be reasonable if there's an ulcer or an acute ulcer. Now, a lot of times, ulcer-like pain can improve with digestive support. So if there's ulcer-like pain, we may ask to try a tiny bit of acid, the tiniest amount, maybe a teaspoon or an eighth of a teaspoon of ACV or lemon juice. If that causes any irritation, we can all acids. We just lean on enzymes. We just lean on maybe some bile salts, and then we work on adding in extra healing and soothing nutrients to help support the gut lining. Conventional medicine are not going to recommend any healing, soothing nutrients. They're not going to recommend glutamine, aloe, DGL, zinc, right? Zinc carnosine. They're not going to recommend any of these high-quality nutrients to help support the gut lining. Go ahead.
Let me point out, too, if you're putting anything with acid on the shelf, it's on the shelf temporarily. We're likely going to bring that in at a future date where... You know, I got into the debate with the GI doc back in the day, and I asked her, well, why do I feel better when I do extra acid and extra enzymes? She goes, no, that's not possible. I'm like, I take more stomach acid. The more stomach acid I take, I feel better. I have less bloating. I have less gut pain. Nope, that's not possible.
Yeah, okay. That's someone that does not have an understanding of physiology, right? Because physiology tells us the more stressed and inflamed we get, the more our sympathetic nervous system is activated. Where does that shunt blood to? Arms, fingers, feet. Why? Run, fight, flee. So all of that goes away from the intestine. So we have a decrease in our digestive juices, and we have a decrease in acidity because that's part of the juices that it produces. And then the acidity triggers enzymes to be produced. So if you have any type of acid irritation, unless we're coughing up blood or we have an active ulcer, I always recommend adding a very tiny bit because sometimes, at least half the time, it can make it better. Sometimes the mucosa is so raw that it can't handle it. So if that's the case, if we can't handle it, we lean more on enzymes and healing, soothing nutrients. If we can't handle it, then we just gently taper it up. And again, we're typically recommending a stool test that's going to look at occult blood. So we're going to get a really good window if there's blood in the stool, or run a conventional blood test that will look at red blood cell, hemoglobin, hematocrit, and reticulocytes. Okay, reticulocytes are young, immature red blood cells. So if we're losing a lot of blood, guess what goes up? Reticulocytes. So if we see a lot of reticulocytes, that could be a sign of blood loss. Now, women could have that because they bleed a lot menstruation-wise and have a lot of estrogen dominance. So you have to understand the context of what you're testing and when.
Yeah, good point. Good point. The calprotectin we are going to be looking at. So that is one marker that does have good overlap from conventional to the functional side. We love looking at calprotectin. That'll kind of give us a clue on just how inflamed is the gut, and is it possible that we could throw in a little bit of acid right away? And I've had people that they have had high calprotectin, and we were able to still do a low dose, maybe 200 to 400 milligrams of betaine, and that was enough to really calm things down, and it improved their digestion so much that we then infer that the malabsorption was creating the inflammation in the first place. And all we did is help them break down their foods better, and then the inflammation always drops. It's so fun to see that. I'm sure you get the same high from it that I do, where you see high calprotectin, you're like, whoa, look at this number. It's scary. We don't like it.
Yep.
Do a protocol, retest, boom, look at the levels drop. It's so satisfying.
Yeah, I would also say a lot of the inflammation and the irritation that is in the intestinal tract can be from poor digestion. So the food putrefies, it ferments, it rancidifies, it basically rots inside your intestines, and that creates its own host of acids that can be irritating. And sometimes taking a little bit of a digestive acid can decrease the rotting acids from the food. So that's kind of the thought process, is a little bit of acid can decrease the production of more acids from the rotting of the food. And big clinical pearl, write this down, I always recommend taking acid with food already in the stomach. People can have false positive ulceration symptoms with HCl by not taking their HCl with food, and that's protein and fat. So I always like protein and fat on the bottom of the tummy, kind of coating it, and then we'll typically come in, if we're on the fence, with a 1/16 to an 1/8 of a teaspoon of ACV or lemon juice, tiny bit in some water. Just a tiny bit. And then that's a good first step, because if you can handle that, then usually you can work your way up. And if you can get to a teaspoon to a tablespoon, then usually we can start to add in supplemental HCl and go from there. But worst case, if we can't, or we're just being more conservative, we just lean more on enzymes. We go to the gut healing nutrients and the third R, repair, right? Repairing the hormones and the gut healing nutrient. It's where we support a lot of the adrenals and stuff as well. We need testing for that. The fourth R is where we come in and knock out infections. Most people on the conventional side, the antibiotic is prescribed first, not fourth. So we set the table so we can go in there and deal with infections better. And then we're using herbs that have more of a broad spectrum but are more selective for the bad critters versus the good guys, which don't create as much of a rebound overgrowth. And then we deal with repopulate, reinoculate good bacteria. And we're not doing just the bifidolongum with a whole bunch of additives. We're doing professional strength, professional grade, high potency antibiotics that have, the amount of probiotics on our labels is where that would be at expiration, not at manufacturing. So when you get a product from us, you're probably getting double the amount that's actually on the bottle. And then 6R is retesting, and we understand that siblings and or spouses may pass infections back and forth. That's really important to keep that in mind when we have a chronic issue.
Yeah, and that's not going to get brought up ever.
No.
I mean, I actually had a medical doc send me an email, and they were mad at me because I blamed the husband's H. pylori reinfection on the wife. And so the wife was working with this doc and was saying, this practitioner, this guy on the internet is saying that I'm the reason that my husband got reinfected with H. pylori. So the medical doc's like, that's not possible. That's not true. I'm like, look, man, I could send you hundreds of cases. I've got before and afters here where we tested someone. We then made a protocol. We got rid of the infection. 2 to 3 months later, the infection comes back. We then test the spouse. Boom, the spouse is positive. Then we put both of them on a protocol. Boom. Now both of them are clear and both of them stay clear. So, I mean, why that would be controversial, I don't know, but it was a funny email.
Yeah, I mean, I have one study right here in front of me. It's called Saliva Secretions in the Efficacy of H. pylori. They're talking about H. pylori was detected in dental plaque and or oral lesions and in the saliva.
When was the year of that study? Just curious.
Yeah, I'll pull it up here right now so you can see it. Let me put it right up on screen so you can
Because maybe,
see it.
Maybe this was a guy who maybe he hasn't looked at a journal in 20 years and he doesn't know that this is possible or true. And then while you're doing that too, I want to say something about the
2011,
approach,
2011. Okay. But there's a lot of studies on this stuff, so there is going to be some H. pylori in the saliva for sure.
Yeah, and I want to talk about the herbs and such too. So the cool thing is with the antimicrobial herbs, those alone can help reduce inflammation. And we may out of the gate, as opposed to saying, hey, here's an acid blocker out of the gate, if we're waiting on testing, if someone's really miserable, it may be 2, 3, 4 weeks turnaround time, we could throw something in right out of the gate that's going to address and calm things down, which is very, very good. We talked about a guy I had that was a teenager with pancolitis. We talked about him a few podcasts ago. But anyway, we got him started on a really potent aloe extract right away. And by the time we got his lab results 2-3 weeks later, he was already significantly better in less pain, less misery. So that's the cool thing is there are some, quote, like, I don't want to call them urgent care, but for lack of a better term, there are some quick fixes that we can implement right away before we get testing.
Totally. And then right here, salivary secretions, the Journal of Dental, I think this is out of Tehran, salivary secretions and efficacy of H. pylori, eradication. So basically they see that, hey, the oral cavity may be affected, right? And they see that there could be saliva could contain H. pylori secretions, and then the conclusion is they find that H. pylori eradication from the stomach may reduce the salivary secretion of H. pylori. So we see that in some of the studies, and this has been around for a while. So it's good to know that. And that just kind of supports our theory that we've seen clinically with spouses passing things back and forth. And again, it doesn't have to be a sexual thing, just sharing drinks and maybe silverware and just living in a house where those kind of things happen easier, right? That increases the chance.
Oh, yeah, we've seen it in kids where it's like, oh, hey, honey, try a bite of this organic dairy-free ice cream. And mom's got H. pylori. Here she has given her 2, 3-year-old the spoon. And then you and I've seen, countless children, 2, 3, 4, 5, 6-year-old kids with H. pylori. And my daughter had it. My oldest, Summer, she had H. pylori. So we tested her gut. She had parasites first. We eradicated those, and then on the retest, H. pylori showed up, and then luckily we were able to get rid of that. So, we clinically and personally deal with these things all day, every day. So we have a lot of sympathy and empathy when it comes to the gut work here. And I just feel for all those people like me that they go to the doctors. You have so much hope. You're so anxious about the appointment. I remember feeling comforted. I remember I was in so much pain. I remember being in that office waiting for the doctor to come in, and I just felt comforted back then. Being in that environment, I'm waiting in the office. I'm like, yes, she's going to come in here. He or she's going to come in here. They're going to give me the answer. They're going to help me. They're going to get me solved. And then my bubble just got burst. I remember walking out of that place just so disappointed. I thought, oh my God, I remember the beginning of my appointment. Here I was so thrilled and happy. I'm going to get to the bottom of this thing. And then here I am, X amount of time later, so disappointed and had to keep searching. So we feel for you. We've been there.
100%. And then again, just because someone has H. pylori, the healthier you are, the stronger your immune system, the better levels of IgA you secrete, which is going to be in the saliva, in your mucosal membrane barriers. That's going to fight these infections. So it's just because you get exposed to it in the saliva doesn't mean you're necessarily going to get an infection. But the more immunocompromised you are, stressed, weaker adrenals, gut barrier integrity issues, poor digestion, the greater chance that H. pylori that's in the saliva could gain a foothold in your body. It's very possible.
Yeah, good point. I'm glad you pointed that out because there's going to be a couple haters eventually. They're going to hear this and go, oh, that's bull crap. 50% of the population has H. pylori. You're painting it to be the bad guy, da-da-da. Well, in the modern world, people are so toxic, so stressed, so immunocompromised that I don't think we can coexist the way we used to because our buckets are so full. So these things do tend to take on a more pathogenic, pro-inflammatory state than maybe previously where people's stress bucket and toxin bucket was less full. So yeah, I'm glad you made that point.
Yep. And then again, not everyone will get exposed to it because their immune system will just knock it out via their IgA. And some may get it, but they're going to be able to be asymptomatic and they're okay. And then they're just like, hey, this isn't a problem. And then they project their good health and their asymptomatic status to, hey, this can't be the problem because I have the same thing. But everyone has a different constitution, and because of that constitution difference, it could affect you differently for sure.
Yeah, well said. Well, I think we did a good job. We covered the testing piece, kind of the conventional colonoscopy, endoscopy, barium X-ray scans, MRIs, CAT scans, CT, swallowing, radioactive tracers, compared to the at-home organic acids and genetic DNA-based stool testing that we're doing at home with people. We compared the drugs, the antibiotics, the acid-blocking medications, the antispasmodics, the immune suppressant or immune modifiers, like you mentioned, possibly in an extreme case like a chemo drug, versus we're going to be going for more anti-inflammatory herbs, natural antimicrobial herbs, antiparasitics, antifungals, possibly some extra acid and enzymes, maybe some zinc carnosine and other things to heal up the gut layer, maybe some additional mushrooms and adaptogenic herbs to strengthen the immune system, possibly using these things throughout the family with spouses or children to help protect them as well. And then, of course, the diet piece, possibly like my dad when he was suffering when I was a young kid and he was suffering with diverticulitis, he was told, eat more fiber. And that was his diet protocol. And it was take, GMO, Metamucil, psyllium husk or whatever it was, right, with natural, it probably wasn't even natural flavoring back then. It was probably artificial flavoring. And that was the protocol versus you mentioned the templates. So possibly low FODMAP, low histamine, paleo, autoimmune, carnivore. There's different things that we're going to do based on our educated guesses, plus with the labs, the information, and then people's food journals. How are they feeling?
And
based
even
on certain
cooking, a lot of times just cooking those foods up better, avoiding raw foods. I mean, that can help a lot, right? The cooking is pre-digestion. And if your tummy has a hard time digesting the food, the more we can pre-digest that food within reason, steam, sauteed, even stews or soups, Instapot, crock-pot, pressure cooker, that can really help with helping the tummy access those nutrients better.
I brought out the Instant Pot the other day. It's summertime. It's hot, so it's not very attractive to bring out the Instant Pot. But man, we threw some organic purple sweet potatoes in that Instant Pot. 10 minutes.
It's awesome.
Oh my God, they were so good.
Oh yeah, like my carb cheat on the weekend is going to be potatoes. Because why? Because they're grain free. They're starchy. I can handle them on the autoimmune side. Some may not be able to, but it's a really good, healthy, safe starch, and it gives you that mouthfeel that you'd miss from breads or grains. So that's my big cheat. And I do 10 minutes on the Instapot on that. It's wonderful. Or, at a nice steakhouse is pretty good too.
It was hard to believe. I couldn't. I mean, it was
great.
a pretty good sized potato, and I thought 10 minutes. There's no way this thing's gonna be done. It was done. We put some butter on that bad boy, some garlic salt. Delicious.
It takes 45 minutes to do that boiling or steaming in real life. I mean, the Instapot is pretty amazing how fast it can cook stuff. It's crazy.
Yeah, this episode brought to you by the Instant Pot.
I know, right? Awesome. Well, if you guys are enjoying this content and you want to share it with family or friends, or you want to dive in and get support from myself, Dr. J, or Evan, evanbrand.com to reach out for Evan, justinhealth.com to reach out to myself, Dr. J. If you guys enjoy the content, we're available. Click down below, whatever source you're listening to this from. We'll have links down below to get access to us. Make sure you give us a comment. Let us know what you think. Let us know what you like. Let us know what parts resonate with you. Give us a comment, like, share, hit the bell for notifications. And we appreciate you guys sharing this with family and friends so they can become empowered about their health. You guys have a phenomenal day. Take care, y'all.
Take care. Bye now.
Bye.
Got a question for Dr. J? Go to BeyondWellnessRadio.com and click the questions button. Then tune in to hear the answer. Also, if you like the show, click below to review us on iTunes. For more Beyond Wellness Radio, go to BeyondWellnessRadio.com.